Okay, good day, everybody. This is Joe Gallo, and I'd like to welcome you to the next segment of the ongoing series AS 101, which hopefully you're all participating in, and we'll have more discussion of that a little bit later. A couple of quick administrative points. Please turn your cameras and microphones off, because it is a very large distraction rather to everyone else when they start to watch. They try to figure out what you're eating or whatever we happen to be doing. There will be a Q&A session afterwards. Initially, it's going to be a video with Dr. Epstein, and then there will be a live session with the doctor. You can put questions into the chat if you are interested. You can also get more questions dealt with at the time of the Q&A after the presentation. There may be an opportunity for you to individually present your questions, but please, what we're going to ask you to do is to use the reaction feature at the bottom of your screen and raise your hand. Don't just jump in, because we're expecting, we've had over 500 registrations for this webinar, so it would be very difficult to try to manage it otherwise. So please don't just jump in until you've been recognized. The standard disclaimer, before I forget, is that anything that is presented today, either by the presenter or other members of the team, is not to be considered as medical treatment or information. You can take anything that you learn here today and take it back to your own medical team. And with that, I would like to then present our distinguished member, Howard Walensky.
Yeah, yeah, thank you, ladies and germs. But I'm Howard Walensky. Please add the cities or countries that you're from. It's good for us to know where you're from. I'm a co-founder of the ASPI group and no longer on the board. I do put out a newsletter. I'm involved with various other things. We originally planned to just present the video we're going to show today. It's outstanding. And it's part of what we call Active Surveillance 101. It's a joint effort of ASPI, ANCAN, Prostate Cancer Support Canada, PCRI, and the Active Surveillor newsletter. The idea was that we were going to present the very basic things about active surveillance by having a couple, Nancy and Larry White. I don't know if they're here tonight, this morning, and they interview his patient and spouse. They interview the leading people in the field. And all of the programs have been good. This one is really outstanding. And, please, send us a note if you have an idea for another subject that could be covered. I'm going to put in the box something about the link to where you can see the whole program. And after we watch the video, Dr. Epstein, and it is Epstein, not Epstein, Epstein, will be available to answer questions. We already have 50 or 60 questions, and they cover the waterfront, and they're focused on active surveillance. And I think that's about all. I'll come back after the video and introduce Dr. Epstein. And at any rate, Bill, why don't you take over from there?
This is Joe Gallo, and more than a year ago, some of us involved in active surveillance support met to discuss programming for 2022. The idea was to try and avoid program duplication through cooperation among support groups. We all agreed that we were not connecting as much as we should with the newly diagnosed men in the gray zone of PSAs 4 to 10 who had not yet been diagnosed. We thought it would be a good idea to develop a series of videos which cover the basics of men and their partners who may be anxious or worried about what was happening to them with no support immediately available. The videos would be a catch-all group of webinars that could answer the many questions a recently diagnosed man might have, all in one place without having to scour the internet. A working group called the Active Surveillance Coalition was formed to develop this series of programs under the name Active Surveillance 101, an introduction or a basic course in active surveillance. The vision was to have real patients and their partners simulate visits with top experts in the field and cover essential questions. Our programs deliberately avoid PowerPoint slides usually shown in webinars in order to replicate as much as possible what a real counseling visit is like. The AS Coalition includes the Active Surveillance Patients International, ASPI, the AS Virtual Support Group from ANCAN, the PCSC Nationwide AS Virtual Support Group from Canada, Prostate Cancer Research Institute, and the Active Surveiller newsletter. Thanks go out to Alex and Peter Schultz of PCRI, who have made the resources of PCRI available to the AS Coalition in helping to produce and edit these webinars. Thank you.
Today, the Active Surveillance Coalition is presenting another installment in its AS 101 series. The Active Surveillance Coalition is comprised of Active Surveillance Patients International, ASPI, the Active Surveillance Group within ANCAN, Prostate Cancer Support Canada, and the Active Surveiller newsletter. Most importantly, PCRI, who help in filming and editing these webinars. This webinar continues to feature Larry and Nancy White, a couple from New Mexico who have been through this journey and are our model patient team. They are visiting Dr. Jonathan Epstein of Johns Hopkins, perhaps one of the best known and admired pathologists in the US and beyond. This webinar is focused on the biopsy report and the many questions our patient team have resulting from the biopsy. Let's begin the webinar now.
Hello, Dr. Epstein. I'm Larry White, and this is my wife, Nancy. It's great to meet with you and appreciate you taking the time, because it seems like it's fairly rare for a patient to actually talk to the pathologist.
Yeah, so it's very nice to meet you, Larry, and Nancy as well. You're absolutely correct. I would say it's more than uncommon. It's rare that pathologists talk to patients. I'm somewhat unique. I probably talk to at least one patient a day, sometimes several. Patients find me either on the internet, various lay books, recommendations from the urologist, and want to discuss their pathology treatment options, and I'm glad to do so.
Well, we certainly appreciate this opportunity. And we've done some research. Nancy has done a great deal of research, and we really have quite a few questions to ask you. But basically, I've had a biopsy with a Gleason score 3+3 or 6, and I'm moving into active surveillance, I think. But we wanted to get a second opinion to make sure that we're within a reasonable Gleason score, so I can be more confident as I move into active surveillance that I'm fairly safe. And we have questions, and so you're going to have a lot of answers, I'm sure. So would it be possible for us to videotape or record our session?
Oh, absolutely.
Okay, thank you. So with a Gleason 6, what role does the pathologist, for instance, have in this journey that one might take to decide whether to do active surveillance or whether or not they truly had cancer? What role does the pathologist play in this process?
Yeah, so the pathologist's role is critical, probably the most critical, because first of all, to establish a diagnosis, number one, that there is cancer there. There are some cases of mimickers of prostate cancer that can be overdiagnosed as cancer, where in fact the patient has something benign. And so that's obviously crucial to get the correct diagnosis. If you have the wrong diagnosis, even if you go to the best clinicians possible, everything else going forward is going to be the wrong treatment. And then even if the cancer diagnosis is correct, about 20% of the times I might change the grade, for example, when I review the biopsies, and that change in grade can be critical in terms of preventing either undertreatment or overtreatment.
Well, and I mean, how important then is it to have a pathologist that specializes in prostate cancer?
Yeah, so most biopsies, just by the nature of the field, will go to general pathologists because there aren't that many subspecialty pathologists who specialize, for example, in prostate cancer or urological cancer. And some general pathologists are excellent, and you'll be getting an accurate diagnosis. But others, you may get a significantly, potentially inaccurate diagnosis. And the problem for patients, and I can empathize with them, is you don't know who the pathologist is. When you choose your care, you might do research and find, I want to go to this surgeon or this medical center because I've heard great things about them and read about them. But the pathologists who are reading your cases, even in a top-notch medical center, you don't know who they are, and they may not have that expertise. That's, I think, a big black box for patients and potentially a weakness in terms of their results.
Well, it seems like it makes it very, very difficult. And so my next question is really, if you had 10 pathologists reading the same slides, how likely is it that they would agree on the diagnosis?
Yes, I would say probably depends which 10 pathologists. But as I said, probably, so I get cases, from all over the country, including outside of the country, sent to me on a daily basis. And at least 20% of the time, I will change the grade significantly. And again, it may be from a 6 to a 7. It could be from a 7 to a 6. It could be literally from an 8 to a 7, or vice versa. So it can be not just in terms of the issue of active surveillance, where it could make a difference, but it could make a difference in terms of whether to get hormone therapy, how much hormone therapy if you're getting radiation. A lot of decision points are going to be affected by the grade.
Well, that's makes it challenging and very difficult, I think, for us patients, in that if I had my study done here on the West Coast and came up with a score that was 3 + 3, and I sent the slides, or we were able to send the slides to you or another independent pathologist, and the score was different, where would we be? And would we have to get a third pathologist, to come in and side with one or the other and give us a better idea as to what our true diagnosis is?
Yeah, so I guess what I would recommend is not to get, in a sense, a vote on what your pathology is, what the quote majority of people might call it, but basically for you as a patient to decide who you would trust. So you have to do the research and find which are the top pathologists in the country for prostate cancer, for example, that you would trust. And for me as a patient, I would go with that person, as opposed to saying, let's shop for a third or fourth or fifth opinion.
Well, how many slides would you say that you review a year?
So the actual slides, I can't even fathom how many slides. So I do about 12,000 cases. And, many of these cases, have more than 10, 15 slides. So, over 100,000 actual slides.
Okay. So another curious thought I have is that in each, let's say, center of excellence, and the pathologist reads the slides, and let's say that they have X number of cases that the prostate was surgically removed. How many of the diagnoses made by the pathologist match the path report after the prostate was examined?
So that's a difficult issue, in that it gets to not just the accuracy on the read of the biopsy, but it gets into sampling issues. So even if you have a very accurate read on the biopsy, let's say everyone agrees it's a 6, there's still a 20 or 30% chance that when the prostate comes out, there's pattern 4 there, just because the pattern 4 was missed. So the discrepancy between biopsy and, for example, a radical prostatectomy, in some respects could reflect a grading error potentially on the biopsy, but in many respects, it often reflects just a sampling issue.
Okay.
But one of the things that you're seeing now in academic centers, which again can be misleading and patients aren't aware of, is that pathologists is often subspecialized. So you may have, in a top place, as you said, academic center of excellence, only urological pathologists who specialize in, for example, prostate, bladder, kidney, and testis, signing out the prostate biopsies. And you might think that's great. But what happens is in many centers, that person signing out the prostate, there's not enough prostates for that person to only do prostates. And so they also have expertise in lung, and they maybe do breast. So they may be doing breast, true expertise might be breast pathology, but they're also doing prostate just because they have to do something else. And so even though you think you're getting centers of excellence where somebody's, you think would be just an expert in urological pathology or prostate cancer, in fact, they just may not be such an expert, but they're doing it because they just have to do something else to basically justify their salary.
Okay, well, it seems like then one of the challenges is to find an independent pathologist then to read the slides for the second or third opinion. Do you have any advice to those of us out there struggling that don't have ANCAN on their side helping us find someone like you? What do you think the best way would be for a patient to find an excellent independent pathologist?
Again, depends on the organ system. So for prostate, there's probably a handful of people in this country that if it were me, I would trust. I mean, obviously I would trust myself, probably, there's, a handful of people out there, and you can find those individuals, by certain societies who would recommend them, like ANCAN, for example. Your urologist also often typically knows who the real experts are in the field. There's also, as I mentioned, lay books out there on prostate cancer for patients who will comment on who they recommend in terms of sending for second opinions. So, I would say, again, probably 5 or 6 people in this country, at least for prostate cancer, is I think if it were me, I would potentially have my biopsies reviewed by them.
Okay, well, if you were, oftentimes patients I feel that my surgeon, who I've been having a relationship with, or my physician, I would feel uncomfortable sometimes questioning their pathologist or questioning whether, that I want to send my path report out for a second opinion. In your experience, how do our surgeons and other physicians react when the patient requests a second or third opinion on the path report?
That's a good question. I would say most urologists, and I would say every good urologist, would have no hesitation and would not make a patient feel uncomfortable for having their specimen sent out. You're not questioning their ability, and you're not necessarily even questioning their pathologist's ability. You're saying, this is one of the most critical aspects of my care, and everything's going to be based on it. And I would just like a confirmation and a second opinion from world expert in this field, on this. And again, a good urologist who's confident, self-confident, doesn't have any hangups about, somebody, asking for a second opinion, should readily say, this is how to go about doing it. That's not a problem at all. And I would say there are many urologists, many of the consults I get are actually from urologists who, and I'm not saying they don't trust their own pathologist, but nonetheless, they want a second opinion before they go on and do a treatment plan and have it sent to me. It's routine. I would say if your urologist gives the patient kind of grief about doing it or makes them feel uncomfortable, I wouldn't say switch urologists, but I would have questions about working with that urologist, because that's just, to me, something that shouldn't be existing. Now, sometimes pathology labs will put roadblocks for patients to send their material, and that shouldn't also exist because it is still the patient's material. It's their biopsies. And so if patients ever do get kind of impediments to having their case sent out to the pathologist, they should persist and, if necessary, talk to their clinicians, and the clinicians basically might hold more sway with the pathology department. And if the clinicians say to them, you have to send this out, usually that'll relieve any kind of hesitancy on the pathology department.
Mm-hmm. Well, that brings up another question then. Let's say that I'm convinced that you're the person that I would like to do the second opinion. How do the slides get to you? Do you ask for them? Does my surgeon request that they sent to you? Or, how do they get to you?
Yeah, so at least for me, we have a website. It's a straightforward one, and it's www.hopkins Consults, so HOPKINSCONSULTS.org. And it's in that website, it basically says if you're a doctor, go here. If you're a patient, you go here. And tells you step by step how to go about getting it done. Typically, it's initiated by the patient to getting in touch with the lab or the lab in either the hospital, it could be an independent lab, et cetera, to say, I want my slides sent out. And again, usually 90% of hospitals or labs will just do it. But again, sometimes they may say you have to fill out this form. Most of the time, it's not an onerous procedure to do so.
When you do the evaluation and you have your report, does the report, or do you talk to me, or does the report go to my surgeon, or what happens with it?
Yeah, so it can be an issue and sometimes a problem. So it all depends kind of how things originate. So with me, so for example, if you don't make a phone call to my assistant, I have a great assistant, Suzanne, who really has been wonderful with patients. But let's just say you just went to the lab, say, please send this to Dr. Epstein. Typically what's going to happen, the slides are going to come from hospital X or lab Y, and we're just going to send that report back to that hospital or lab, not to you and not even necessarily to your urologist, because all we know is it's coming from this hospital or lab. In that situation, the original institution, it's incumbent upon them, they should send a copy of that report to your physician. Now, they should, whether they 100% do it, I can't say, but they should. And it would be up to you to basically either call me and say, do you have a copy of the report? My system would get it to you, or to call the lab or your urologist saying, I sent this off to Dr. Epstein, I haven't gotten a copy. Can I get it? What's going on? So it's kind of incumbent upon typically the patient, because the reports aren't automatically going to go to the patient unless they ask for it. Now, if a patient makes a request and let's say contacts, me or my assistant, say, can I have a copy of the report? 100%, we give you a copy of the report. But it's not something that'll automatically necessarily happen because just the flow of how the system works.
Okay, well, as I said in the beginning, my wife Nancy has really done a great deal of research, has been a part of NCAM, and has done so much work while I've worked. And so she has quite a few questions and knows more than I do, I think, about prostate cancer. So I think she has some questions.
Yep, I have a question.
I just want to say before you go, I would say probably I speak more often to the wives of the men with prostate cancer than sometimes the men. And as you say, many of the times they're more informed, have done more of the research than the men on this issue. So,
but one of the things that we certainly think is important is that, any cancer, but prostate cancer is certainly a family affair, not just that of the man. So Nancy's has some questions for you. So,
Dr. Epstein, does the second pathologist often have trouble understanding the labeling protocol used by the original institution that took the biopsy? We have a friend who had this occur, and the second opinion doc did not even think he had the whole set.
Couple issues, yeah. So every lab, many labs do things different, label things differently. You have their slides or kind of how the tissue is on the slides very differently. Sometimes it can be very confusing. Because I do so many cases and they're coming from all over the place, and I see all these various types of way the slides are handled, I'm used to it and I can decipher it quite readily. But I would imagine for somebody who doesn't see them, there is a chance that they could definitely have difficulties in how they're arranged. In terms of the issue, like you said, it's also what material is sent. Sometimes they'll only send the cancer slide, sometimes they send the whole case. So it can be variable. I've had cases also where they didn't send the key part of the case, the highest grade cancer. And in those cases, we will reach out to the lab and say, we don't have all that we need. We need to see everything. But what I would stress from a patient standpoint, if you get back a report and you feel it's incomplete, they didn't see all the slides that you would want them to see, again, reach back out to the institution and or to the second opinion individual and say, can you try to rectify that situation?
So it's not that uncommon.
No, not that uncommon.
So, and then just for basics, what is the Gleason score and how high do they go?
Yeah, so the Gleason score, basically was back from the 1960s and 70s. So obviously it's decades ago. And prostate cancer often has several different patterns, both low, less aggressive patterns, and sometimes higher grade or more aggressive patterns. And so Gleason came up with a unique system where you say, what's the most common pattern? What's the second most common pattern? You add them together to get a score. And if only one pattern is present, you just double it so it stays within the framework. So theoretically, Gleason grades go from 2, 1 plus 1 equal 2, the lowest grade, all the way up to a 10, which is a 5 plus 5, the worst grade. But even though that's theoretically the scale, grading basically starts at 6, a pure 3 plus 3. We don't use patterns 1 and 2 anymore. So, and that's why we came up with this I came up with this grade group system of 1 through 5. It's much more intuitive to patients. And the lowest grade you have is a 1, which everyone understands is good.
What is the difference between Gleason 6 and grade group 1?
Same thing. So grade group 1 and Gleason 6 is the same thing, but grade group 1 would also be Gleason score 5, Gleason score 4, 2, and 3. Right.
Okay. And what determines if Gleason 7 is favorable or unfavorable?
Yeah, so that's a complicated question, and a question that probably will evolve over time. So there are several things that we do know that I think is important. So within a 7, you have 2 major breakpoints. A tumor can be a 3 plus 4, where you have more 3, the good tumor, lesser amount of the higher grade pattern 4, that's a 3 plus 4. Or you could have more 4, more of the aggressive component, lesser amount of the pattern 3, and that's that would be a 4 plus 3. But even within a 3 plus 4, you could have anywhere from 1% pattern 4 to almost 50% pattern 4. So a tremendous range. Same thing within a 4 plus 3. You can have 60% pattern 4 or 90% pattern 4, bordering on a 4 plus 4. So one thing that pathologists should be doing, but I would say only a minority are currently doing, is giving the percent pattern 4 when you have a Gleason 7 as your highest grade. So again, somebody with a 3 plus 4 equals 7 with 1% pattern 4 could be a candidate, for example, for active surveillance potentially. But somebody with a 3 plus 4 equals 7 with almost 50% pattern 4 bordering on a 4 plus 3 wouldn't be a candidate for active surveillance. But unfortunately, if you just say Gleason 3 plus 4, clinicians, patients, no one knows where you are in that spectrum. So that's one thing that I think pathologists should be doing. It's been recommended by the major pathology societies, but I would say only a minority of pathologists, especially out in the community practice, are doing it. There's also, within 7, there's different patterns of 4. Some potentially are more aggressive than others. And one pattern is called the large cribriform pattern that's more aggressive. So for example, in our pathology reports, we will note whether this large cribriform pattern is present or absent. Smaller cribriform glands, I think, is less clear, and so I don't comment on them. Some other pathologists may comment on them, but I would say probably if a minority of pathologists are commenting on percent Gleason pattern 4, it's even rarer for pathologists to comment whether they're cribriform or large cribriform glands. But that's, again, something that I think is evolving, but still important.
So it's complex whether favorable or unfavorable is the descriptor.
Yeah, so right. I think there's a spectrum of 7, and there are probably, it's called intermediate grade. There's a favorable intermediate grade and an unfavorable. And I think the easiest thing to understand is probably the percent of Gleason pattern 4 is critical in that respect.
Right. And what if a patient has a very high volume of Gleason 6? What does that mean for active surveillance?
Yeah, so again, good question and kind of controversial and maybe unclear. So strictly speaking, even if you have, let's say, multiple cores with Gleason 6, a lot of the cores extensively involved with Gleason 6, you would still fit as a candidate for active surveillance. But the more volume of cancer you have on your biopsy, the higher likelihood is that there may be unsampled higher grade cancer in your prostate. So what I always do when I talk to patients and they're considering active surveillance, first I always discuss with them. There are some patients who just don't want active surveillance. They don't want to wake up every day thinking I have cancer in me. They just want it taken care of. So that's, it's a personal decision. But if somebody's interested in active surveillance and they're a candidate based on their pathology, let's say they have a Gleason 6, The first thing I ask them is, have they had a multi-parametric MRI? Because the biggest problem with deciding whether somebody's a good candidate for active surveillance is who has a Gleason 6 on the biopsy is whether that's an accurate representation of what's in their prostate, or is there a significant chance that there could be unsampled, more aggressive cancer where they would not be a candidate for active surveillance. And probably the biggest breakthrough, one of the biggest breakthroughs for patients for prostate cancer is multi-parametric MRI. It's not foolproof, but it definitely improves the detection of higher grade cancer. And so to be able to target and sample those areas where there's a higher likelihood that there may be more aggressive cancer. So if anybody's considering active surveillance on their biopsy and they have not had a multi-parametric MRI, that's the first thing I would recommend. They need that done to make sure that their biopsy, to the best that we can do, nothing's perfect, has tried to rule out that there's worse cancer there.
So there are a few terms I've heard that I'd like to better understand.
I have a question. So that brings up, so once you get the MRI, and the MRI is going to hopefully show you where the greatest likelihood of cancer might be to better inform the biopsy. So the prostate, is it, what's the best way to do the biopsy? Is it like rectal or perineal in terms of, let's say it's the cancer is way in the front, or, is it better to do one than the other? Who do you go to for your biopsy now? Is somebody that does perirectal or anything? Yeah.
Yeah. Again, excellent question.
Yeah.
So again, there's a significant chance of biopsies missing cancer, and sometimes the cancer that's missed is significant, both volume and grade. And even with the multi-parametric MRI, there's a potential of missing cancer. You bring up a good point in that one of the areas where cancer is more readily missed is the anterior front part of the prostate, kind of away from the rectum, where the transrectal biopsies or biopsies that go through the rectum sample the back of the prostate, the posterior part, could miss a large tumor in the anterior region. So if the multi-parametric MRI identifies a large anterior tumor or an anterior lesion to target, probably transperineal biopsies better sample that anterior region. That's one of the advantages of those. So you might consider that. On the other hand, if the transrectal biopsy finds high-grade cancer, then that's it. It's kind of done anyway. So it depends.
Okay.
Yeah. So there are a few terms I've heard that I'd like to better understand, and you already covered one, cribriform, and then another one is perineural invasion.
Yeah, so perineural invasion is common in prostate cancer. For example, in radical prostatectomies, it's present like 85–90% of the time. So we don't even mention it in the radical prostatectomy. It doesn't have any prognostic significance. On needle biopsies, it's something that's evolved, and kind of in some points of time, it's been considered very significant, sometimes not that significant, now maybe becoming more significant. So research that we've done just very recently, literally the study's not even published yet, but one has been accepted for publication. Another work we're right in the middle of getting it accepted, has shown that perineural invasion is a kind of an adverse feature for active surveillance. Now, it's not so adverse that if somebody has it on the biopsy, you would say, don't undergo active surveillance, but it kind of raises a red flag saying that you might not be the optimal candidate. You want to be followed more closely, get repeat biopsies. It's just one other piece of information to factor in.
And high-grade PIN, prostatic intraepithelial neoplasia, is that cancer?
Yeah, so high-grade PIN is a confusing term and probably should be changed in the future. Again, something that's evolved in the past. So it's not cancer, number one. It's kind of a precancerous lesion, but what I would stress, it's a precancerous lesion to more indolent cancers usually. So not that bad of a precancerous lesion. And whereas in the past, if let's say you had only high-grade PIN on your biopsy, no invasive cancer, it would have been a finding to prompt the urologist to do a repeat biopsy to look for cancer. More and more studies have come out, and good studies have come out, showing that for the most part, if you get a good biopsy, you follow somebody up with make sure they have a multi-parametric MRI biopsy. If you have high-grade pin on your biopsy, that shouldn't be a determining factor of what to do. You pretty much almost ignore it if you have only high-grade pin. And if you have invasive cancer, 6 or 7 or whatever, and high-grade pin somewhere else, again, definitely ignore it. That means nothing. So not something. Now, the bad thing, unfortunately, and I think hopefully we can change the name, the word high grade in front of that pin makes it sound more worrisome for the patient, because they confuse that with high grade cancer. And again, it's a bad name, basically.
Right. I agree. Intraductal carcinoma.
Yeah, so this is also a precancerous lesion, but an aggressive precancerous lesion. So in contrast to high-grade pin, intraductal cancer either represents invasive cancer that's very aggressive and breaks into benign glands and grows into the ductal system. Kind of think of like a bunch of pipes, the benign glands, and this cancer is so aggressive it can break into those pipes and start spreading. So that's a bad prognostic feature when you have intraductal cancer. But in the uncommon situation, if you have intraductal cancer only on your biopsy, no invasive cancer, that's something that's also very worrisome. And either those patients should be treated with radiation or surgery, or definitely get a repeat biopsy to look for cancer, because the vast majority of those patients have aggressive cancers, not just cancer by itself. So it's a worrisome finding. But I would say the other thing I'd emphasize is just like there can be differences amongst pathologists and their expertise in diagnosing and grading usual prostate cancer. Pathologists who don't have a lot of expertise are going to have a lot of problems with, for example, intraductal cancer too, either overcalling it or undercalling.
So where do biopsies fit in versus genomic testing?
Yeah, so there are mostly commercial companies that do the genomic testing, and that's not saying it's a negative thing. They just basically have the money and to be able to do some of these, to develop some of these testing. But they also have a financial incentive to do these testings, which I think sometimes can play a role in terms of how these tests are put forth. From the standpoint of active surveillance, I have some concerns about how useful these tests are. The biggest problem with active surveillance is missing higher grade cancer. If we could have a crystal ball and look into the prostate and say, this is exactly what's going on, it would be an easy thing. And I would feel much more comfortable in terms of active surveillance overall. But that's not the issue that we have. And even with the best things that we do, multi-parametric MRI, extensive sampling, we still miss sometimes the worst cancer. The problem with the genetic testing is you're just sampling and testing whatever's been sampled. So if you have this lower grade area, or even a multifocal separate low grade cancer that's on your biopsy, and you do the genetic testing on that, the molecular testing, that's not necessarily reflective and going to reflect what's the molecular of aggressive cancer somewhere else. The hope was that molecular could say these are good 6s and bad 6s, and that the 6s that look under the microscope just like a regular 6, if there was worse cancer somewhere else, the molecular would be able to detect that's a cancer that's associated with bad cancer somewhere else. It hasn't really panned out like that. So I'm not a big advocate of doing molecular testing when you have a 6 on a biopsy and you're trying to decide whether to go active surveillance or not. Now, if you have a 7 on a biopsy, a low volume 7, for example, and you're still potentially considering active surveillance, maybe the molecular could help in that case. I don't think the data is out yet. The way I consider molecular is just one more piece of information. But it's not something I would typically rely on to make my decision.
Do you have an opinion on who ultimately qualifies for active surveillance? And what criteria besides the Gleason score would you use to determine this? And for me, the big question is when do you move from active surveillance to active treatment? What is that point that you would think would get you there? So those kind of 3 issues.
Yeah, so a lot of things I think go into a man or their whole family deciding whether to go for the patient to go on active surveillance. One is, as I mentioned, just the comfort level patients have with undergoing active surveillance. I mean, some men and families are comfortable with it, and because there, no matter what you do, there is still a risk that there could be more significant cancer that goes untreated for a period of time. We think we can catch it even if we miss it initially and treat it, but everyone has seen cases, myself included, where somebody's on active surveillance for multiple years, and all of a sudden there's a Gleason 8 or a 9, and you question, what if I had done something different? So there's that comfort level with, to some extent, uncertainty. But assuming, let's say, a patient wants to undergo active surveillance, first is the grade. I would say extent of cancer is also potentially a factor. Age is critical. I mean, if somebody, they're older, and it's, it's continuous scale, if somebody's older or has a lot of comorbidity where their lifespan is going to be less than 10 years, for example, I would say much more likely to go under active surveillance, because the chance of their cancer hurting them in that 10-year frame would be a lot less likely than somebody who's 50 who has 30, 40 years ahead of them. So that's something to factor in as well. Other things that I guess I would factor in, again, molecular to me isn't something as critical. Probably those are the most important thing is be grade, extent of the cancer. The other thing is the PSA value. It's been shown, especially PSA density, we have always found to be even more important than PSA, where you take the PSA and you factor in the size of the prostate to account for that as well. Because if somebody has a high PSA density, reflecting typically a high PSA, even if their biopsy findings look favorable, that's often a big red flag that there is worse cancer there in that patient that just hasn't been sampled. So PSA density is something I would start factoring in. Perineural invasion as, again, one more factor. Whether there's large cribriform glands or not, another factor. Percent Gleason pattern 4, another factor. Those are all kind of the things that I would be factoring in. And in terms of what prompts somebody to go from active surveillance to treatment, typically it's even a rising PSA usually isn't something that leads to active treatment. If somebody has a rising PSA, for example, that's very rapidly rising, that's, again, usually a signal to that patient needs another biopsy to look to see if there's more aggressive cancer. But just by itself, you wouldn't use that rising PSA to actively treat that patient. Similarly, it's been shown that having serial multiparametric MRIs, most of the time, it's not going to change that much. So it's unlikely that a change in an MRI finding is going to prompt treatment. And again, you wouldn't do it solely based on the imaging, because sometimes the imaging isn't accurate. So the one thing that really drives potentially switching from active surveillance to treatment is another biopsy showing worse tumor. Now, historically, it's been that if you went from a 6 to a 7, that was enough to say, okay, you need active treatment. And still, 85% of the time, that's what's happening currently in the United States. 15% of the time or so, some urologists are saying if somebody has a 6 and they have a 7, 3 plus 4, they may still be a candidate for active surveillance. And what I would say in that situation is I would look at that 7. What type of 7 is it? Is it a, quote, a good 7 with a small amount of percent pattern 4, no large cribriform glands, no perineural invasion, PSA is not that high. If all of those things line up, that might be an individual where even if you have a 7 on a repeat biopsy, you've had your multiparametric MRI, you might still be able to stay on active surveillance. But that's, I would say, is an evolving field. So literally, we're just in the middle of a study to submit, looking at that issue of men who have a 6, have a 7 on repeat biopsy, and we're trying to say who are the good patients that we think might be able to stay on active surveillance. So I think there's a growing amount of research to try to keep as many men as possible on active surveillance, but still doing so in a safe manner.
Well, thank you. That was really informative, because that's my issue is, okay, I'll do active surveillance, but boy, trying to figure out when and if a change occurs. I mean, it might be 10 years, who knows, but when one would really want to move into treatment, because the thing is I don't anyway, want to have metastatic disease.
Right.
And which brings up the other issue is my dad probably died of complications to prostate cancer. So I talked to some doctors earlier, is that my initial idea was that if I had prostate cancer, I'm having that thing ripped out.
Sure. Right.
And over time, in a decade or so, and I did end up with this biopsy, I've kind of changed a bit, and I think there are many other options now besides surgery, and active surveillance seemed like it might work for me. So
yeah, it's very confusing. I can empathize with patients. I mean, it used to be straightforward. You had basically surgery, maybe one form of radiation, and that was it for your choices. And now, I guess you could say it's good. There are many choices, but choices are confusing. And so it's not just surgery versus radiation versus active surveillance, but it's also, there's like 10 types of radiation therapy that are out there. And when do you use hormone therapy? How long do you use hormone therapy if you have radiation? So it's, and I would stress, just like I think it's critical to get a second opinion from a pathologist, an expert pathologist, same thing, get a second opinion from, 2 radiation oncologists, if that's what you're thinking. Or many institutions have a multidisciplinary clinic. Hopkins has one where there's a group where you meet with a surgeon, radiation oncologist, a pathologist to discuss all the options and decide where to go, because it's not a simple decision.
it's not, and you've just described my journey, and I think many individuals' journey on this, because it is there's nothing clear cut really, and things are evolving all the time. Even whether or not 3+3 is really cancer or should be considered cancer is kind of an issue that seems to be bubbling up. Do you have an opinion on that, or?
Yeah, so that's been kind of a hot topic on and off. I've done several articles, kind of the pros and cons, and even some YouTubes and some other, debates. So as a pathologist, but also as somebody who understands the disease and what it means to the patient, I still think we should be calling it cancer. As I said, if we had a crystal ball and if you had a Gleason 6 on your biopsy and I could look in your prostate and say that's all you have is a 6, I might be fine to say, let's not call it cancer, because if you have only 6, that tumor cannot spread anywhere else, in a sense. It doesn't behave like a cancer. But because there's a 20-30% chance if you have a 6 on a biopsy, there's worse disease, my fear is that if we don't call it cancer, patients won't be followed as carefully and won't undergo repeat biopsies, which are, painful, have complications, et cetera. They'll say, why should I have repeat biopsies? Why should I be going, getting all these imaging studies done and blood tests done every year if I don't even have cancer, and won't be followed carefully? And I think the key thing for active surveillance is that anybody who's considering active surveillance has to be on a sense of program. It's something that you don't take lightly. You want to go to a center or be involved with the urologist who takes care of a lot of patients with active surveillance, to know what the latest in the field is, and when potentially, the latest information that comes out to maybe keep you on active surveillance that otherwise you wouldn't, et cetera. So the problem by not calling cancers, I think patients will slip through the cracks and not get followed as carefully. There's a lot of other reasons why to call it cancer from a science standpoint. That's probably not as interesting for the patient, but under the microscope, molecularly, it is cancer as well. But I think just from a patient care standpoint, it's reasonable to call it cancer. The arguments against calling it cancer, the main thing is the whole fear of the word cancer, that when patients hear it, they're going to say, I need treatment. I can't go on active surveillance. I have this, I've been drummed by everything that I've heard on throughout my life, cancer, treated early. But I think patients are, learning, and I think, it's up to the urologist often to impart to the patient that, yes, you have cancer, but some of these prostate cancers are good cancers, indolent cancers, and doesn't mean you do nothing. It means we follow you carefully. That's why we don't use the word watchful waiting. Watchful waiting implies a passive approach. Active surveillance it's an active approach. We're going to follow you carefully, do repeat biopsies, repeat imaging, follow your PSAs. And hopefully, we're not going to let you fall through the crack. And I think the issue about changing the name from cancer to not cancer is, in the past, 90% of men in the United States, if you had prostate cancer, were being treated, even though many of them probably could have gone on active surveillance. But it's changing. I think, in many countries, Sweden and Canada, it's the opposite. 90% of men who are candidates for active surveillance do active surveillance. Now in the United States, maybe it's 50 to 60%, but that's an improvement. And I think the goal is, hopefully we'll get up to where Sweden and Canada is, and that all the patients who are candidates for active surveillance choose it. And I think the most important thing is for urologists, because they're kind of the gatekeepers, to buy into active surveillance. And I think more and more are doing so. But that's where, if a clinician says, you need treatment and doesn't give the patient the option for active surveillance, that's where patients potentially are getting overtreated.
Well, you've been so helpful, but before we let you off the hook here, what do you think about, or is there any role for artificial intelligence in examining the biopsy?
Yeah, so there, AI, like everywhere else, is being investigated in prostate cancer. And there's several groups that have looked at grading with AI because, as we highlighted before, some of the problems with, inter-observer reproducibility and subjectivity of grading. There may be a role right currently there. It's not being practiced with AI. The problem with AI is, number one, it's only as good as whatever you put into it in terms of the material. But the other problem is biopsies have a lot of artifacts. There's folds of tissue. There's unusual things that pop up in the biopsies that are not, the AI wouldn't have been trained on. It's like driving a car. I mean, right now, I would not feel comfortable, being in the back reading a newspaper while my car is on AI. I mean, yes, if your hands are on the wheel and the car is parking, that's one thing. So, at this point, you could do AI for grading prostate cancer, but I'd want a pathologist looking at that also to making sure that it didn't go off way on some wrong tangent because of artifacts, et cetera, or miss something totally. I mean, it's been shown with AI, for example, certain percentage of cases, it's going to overdiagnose cancer and underdiagnose cancer because, it just wasn't trained to pick up certain things. So, might have a role, but my fear is potentially, just like the analogy I use with a car, somebody sitting in the back seat. My fear is that if pathologists, if AI gets out there and pathologists potentially could use it, that they will rely too much on it and not, use it as an adjunct, but use it just, hey, I don't know how to do this work, where there could be potentially a serious error.
Right.
Yeah, I'm not even sure medical legally what happens. I mean, I imagine when these AIs come out for grading, there's going to be a big something disclaimer saying, if this computer makes a mistake, we're not liable, so.
Yeah.
You have been so helpful. And, it's just great talking to you. And do you, we've asked a lot of questions, but do you think, do you have any ideas of what we could have asked, or any other information that you might think we've left out that another patient, another person might need?
Yeah, I mean, there's always, I think, individual aspects of treatment that patients will ask. In terms of active surveillance, I think we've covered pretty, the waterfront. I talked to some patients who have more advanced disease, and it's a whole, another series of questions.
Mm-hmm.
But yeah, I think we've, covered things. And what I always encourage patients when I talk to them, sometimes after they get off the phone with me, I'm sure some other questions pop into their head. So I always encourage them, if you have other questions, don't hesitate to reach out and touch base with me. But one of the things they always stress, which is unfortunate, again, I think most clinicians are excellent. Most clinicians take time with the patients, but I think the patients who often reach out to me, they often tell me, my clinician just doesn't want to talk to me about all the things in my path report or all the options that I have, and they're just too busy. And that's when, they reach out to me. And ideally you want to have a clinician that's going to be able, such a critical, decision-making that you have, you want a patient that's going to give you that time to be able to have the discussion just like we're having here today.
Right. Well, boy, thank you so much.
Thank you.
It's my pleasure.
We really,
But it's great to talk to very well-informed patients. And I think it's great more and more that patients are informed and read about their disease and get involved in their treatment and ask for second opinions when it's appropriate. And I think their patients are the best advocates.
Well, not to give a big, to give a shout out for NCAN. That is an organization that has been so helpful to me, so helpful for Nancy in our decision making, and broadened our thinking, and got us connected with you and others that have been so important in our journey. NCAN, boy, I have nothing but high praise for the organization, and of course for you. So thank you.
Thank you so much. It's been great talking to
Thank
you.
you. Thank you.
Yeah.
Good luck. Bye-bye.
Once again, I'd like to thank all the participants in today's webinar. We are really appreciative of Dr. Epstein giving us his time and knowledge for this webinar, and to PCRI for all their help. Please look forward to our next webinar.
Hello, Dr. Epstein.
Hi, how are you?
Good. Again, I'm Howard Walensky, and that was a very comprehensive review. I think with Nancy and Larry White, we still are loaded with questions, and we'll get to those. But I'm going to give you a little bit of an introduction. But how do you introduce a person who needs no introduction? Many in the audience have already obtained second opinions from Dr. Epstein. I did nearly 13 years ago. I estimate he has reviewed the slides and rendered a second opinion for more than 150,000 patients since me. So that's a lot to keep track of, and that's not counting all the slides. I just want to give him another plug, which is I consider him the patient's pathologist. Most pathologists, and I've dealt with a lot of them. I wrote a book for the pathology organization, so I know a lot of pathologists. Most pathologists prefer to be a doctor's doctor and let the patient's urologist explain the pathology report. Dr. Epstein of Johns Hopkins is happy to go over his report with patients. So without further ado, we'll begin to ask questions. I'm going to ask some icebreaker questions, and then I'm hoping one of the other moderators will pick up questions that have popped up in the chat box, and you can add more, but I don't know if we're going to be able to answer all of them. Also, be aware that this is going to be recorded, so if you have to go, we'll keep going and it will be available. You'll be notified automatically. At any rate, so I'm going to start. Also, look in the chat box for Dr. Epstein's website. And I'm going to start off with a question that I have a feeling you're not going to answer. In the recording, you said there were 4 or 5 pathologists in the country you would trust to read all of these tests. And I assume you're one of them, but can you clue us in on who the other 4 are?
I think you're right, because if I listed the 2 or 3 or 4, there may be other pathologists who would be very upset they're not on the list. So I think from a political standpoint, it's probably best for me not to go there.
So, but you'll whisper those to us, huh?
Absolutely.
At any rate, in the video, you mentioned high volume Gleason 6, but there's another topic that I want to ask you about, which is very low risk prostate cancer. I would guess most of the people in the audience probably have never even heard of that. And yet you were instrumental in developing this idea going back to the 90s, I think. So what is very, very low risk, and who qualifies for it, and why has the American Urological Association dropped this classification while the other big guideline group, the National Comprehensive Cancer Network, has held on to it? And what percentage of patients are considered very low risk?
That's a good question. And so basically, within, for example, patients who satisfy a criteria for active surveillance, there are some who are the ultimate candidates with the lowest risk prostate cancer. And actually, in the whole debate, is Gleason 6 cancer or not, there's a group of urologists and myself and another pathologist who've come up with a way of trying to, while still calling it cancer, come up with a different way to express these very low risk cancers to hopefully alleviate some of that fear of cancer. I can't go into great depth on that now because it's confidential, it's being submitted to our journals. but trying to come up with a compromise to explain these are really low risk with terminology. But very low risk cancer, so low risk cancer basically says Gleason 6 and a PSA of less than 10. It doesn't factor into account how much cancer is on the biopsy. So you could have 10 cores of a Gleason 6, each core, full of Gleason 6, and that's still low risk. But those patients with that type of a Gleason 6 cancer are at high risk of having worse cancer somewhere in their prostate. If there's a correlation with volume of cancer and grade, so the bigger the cancer, more likely there's a chance of higher grade. Not always, but more likely. So our very low risk criteria is basically only 1 or 2 cores that are positive, and no core has over 50% of cancer, along with the PSA of typically being less than 6.
But, so here we have 2 leading guideline writers, the American Urological Association and the NCCN, taking opposite opinions. And so what's a patient to make of that?
Yeah, so I think, and I can't speak for the AUA why they dropped it, but there is a difference prognostically between very low risk and low risk. I think the concern potentially, I can imagine by the AUA, is they want to expand active surveillance to include most low risk patients, and potentially by having a very low risk and a low risk separation, that may worry some patients who are just low risk, thinking, oh, I don't have very low risk, I'm not a good candidate for active surveillance, whereas most of them still are. That's the only reason I would think why to separate them out. But I still think it's helpful to keep that in mind, especially for a younger patient. I think it can be reassuring to patients when they're very low risk. And it turns out over 50% of men with Gleason score 6 are very low risk. So again, I think it can be reassuring to the majority of men who have a Gleason 6 or grade group 1 cancer that they are in this very low end, extremely low end, where they're ideal candidates for active surveillance.
So wait a minute, you're saying 50% are very low risk? Is that amongst the low risk, or?
Yeah, so compared to, right, I'm saying within Gleason score 6 cancers, not all across the board, but men who have Gleason score 6 cancers, over 50% of them will be that very low risk group.
But if you take all the men with prostate cancer, what percentage fall into the broad category of low risk?
I don't have those numbers off the top of my head. A lot of it's going to be also dependent on how the prostates are sampled. If you're doing it on multiparametric MRI, which tend to sample the higher grade areas, and often Gleason 6, smaller cancers aren't even visible, you're going to get a smaller percentage of Gleason 6 is low risk. So a lot of it will be dependent on who you're biopsying, probably more than anything else.
Well, moving on to, you mentioned high cribiform images findings, but what's the difference between that and low cribiform? And are all pathologists as concerned about this as you are?
Yeah, one area in prostate pathology where I would say the majority of pathologists are still not kind of, in a sense, up to speed and not providing the material, the information in the pathology report, is to report the percent Gleason pattern 4 with the Gleason 7. And I'll get to the cribiform in a second. But for example, if you have a 3 + 4 = 7, you can have 1% pattern 4 or close to 50% pattern 4, bordering on a 4 + 3. That unequivocally, GU pathologists agree, and all GU pathologists are pretty much reporting that factor because that's undeniably important information. But still, I'd say 50% of the cases I get from all around the country, pathologists, when they sign out the cases, don't give percent Gleason pattern 4. The issue of cribiform Gleason pattern 4 is more controversial, and consequently, I would say only a very small fraction of pathologists are reporting it, and how they report it also differs between pathologists. And the reason why it's controversial is when you look at the studies, if you just look in a very broad-based, high sky value, high sky kind of looking down and saying, is cribiform cancer bad? The answer would be yes. But once you dive deeper into it and look at it in terms more carefully, a lot of the studies that have said cribiform cancer is bad have not separated out intraductal cancer versus cribiform cancer. As I said in the video, intraductal cancer we know is very bad. So many of the studies that say cribriform cancer is bad, that may not be true in those studies. It could have been the intraductal cancer was bad, not the cribriform cancer. Also, there is a broad spectrum of cribriform cancer, small little cribriform glands, large cribriform glands. Almost all pathologists agree the large cribriform glands are bad. Not a lot of good data and not a lot of data, period, where the small cribriform glands are bad. So consequently, what I've adopted in my practice is to only report where the large cribriform glands are present or absent, because I'm not comfortable saying just cribriform cancer is present, including the small cribriform glands, because that could unduly worry patients, clinicians, maybe lead to overtreatment, where I just don't think we have enough data. Now, maybe eventually down the road, we will have data and I'll change my practice. But currently, to me, the only data that I'm comfortable with is that large cribriform glands are bad. And when I see that, I'll report it. That ends up being a finding in a very small minority of prostate biopsies done for early prostate cancer.
Now, I think you did touch on the issue of age, but maybe you can define that in a different way. We have a note here from Bill from Canada, who's 82 years old. And he's been on active surveillance for, I think, 13 years. His dad died from prostate cancer. Now he's been upgraded to 3+4, small amount of pattern 4, less than 5%, but with evidence of cribriform. That aside, what age can we get off this biopsy boat?
Right. So I would say an 82-year-old man with a 3+4 = 7 with a little bit of 4, I would still do active surveillance. The chances of him dying of his cancer is much, much less over 10 years, for example, than potentially dying of some other cause. And to undergo the potential morbidity associated with cancer treatment, the risks with that, I would say, strongly are outweighed versus the benefit of treatment. So I think at age 82, it becomes a clear answer. It becomes more problematic when you're in your 70s, let's say early 70s, in terms of what to do. Now, typically what's being recommended is by age 75 to stop screening for cancer and stop doing let's say if somebody's on active surveillance and at age 75, they reach 75, they're doing well on active surveillance. What we're doing at Hopkins is, it used to be that we would just stop active surveillance at age 75. And then we had some patients who several years later were found to have very aggressive cancers, even dying of the cancer. And when we looked at their imaging, they had these big tumors. And those big tumors didn't pop up from age 75 to, let's say, 77. They were there when they went off of active surveillance at 75. So what we currently do is, before we decide to take somebody off of active surveillance at, for example, age 75, we'll do a multiparametric MRI just to make sure there's no big cancer there that we would consider wanting to treat at that time. If at age 75, there's not an obvious, aggressive cancer there, then we will stop doing active surveillance and stop doing repeat biopsies, PSAs, et cetera.
Let me make a distinction here, just to be clear. Okay, there's also guidelines that say stop screening at age 70. But what you're talking, there's a difference there, isn't there? I mean, between men who are, like probably most of those in the audience, who have been diagnosed versus the 70-year-old or the 75-year-old who's never been diagnosed.
Right.
There's a difference, right?
Yeah, totally different, right? And so there's also, and it's a tricky distinction, and each patient has to make their own decision. There's a distinction between kind of society decisions versus individual patient decisions. For example, based on statistics, if let's say at age 50 something or even 60 something, your PSA is 0.5, you have an extremely low risk for the rest of your life of having a serious cancer. And you potentially could not even be screened going forward. Having said that, there are some men who, even with that low PSA, will develop significant cancers, even die of cancer, if they are not potentially screened going forward at age 60 or 65. But from a society standpoint, just looking at hundreds of thousands of men, cost effectiveness, the answer might be don't screen. But you as a patient might say, I don't want to take that risk of being that 1 out of 100 patients who wakes up with, metastatic prostate cancer at age 65 because I stopped screening at 60 just because my PSA was low. And for example, I'm one of those patients. I've been having my PSA tested since I was 40 because I see all these men with prostate cancer in their young age, and I've just decided I'm doing it. And my PSA has always been, 0.2, 0.3. And, I'm going to keep on testing myself because, again, I want to be safe rather than sorry. And I feel I can make educated decisions if I am found to have cancer, deciding whether to go on active surveillance or not, et cetera. But from a guideline standpoint, the guideline might say, don't test if your PSA is super low. And this, I'm talking about patients who've never been diagnosed with cancer. If you reach a certain age and your PSA is low, and you may decide not to do it, and that's your personal decision, but recognize none of these guidelines are 100%. It's based on an overall statistical likelihood for a large group of men, for society, what's cost effective. And as an individual, you have to decide what you want to do.
Well, I know two guys on active surveillance, one of them 82 and the other 84. The 82-year-old said, I think I've led a good life. I think I want to be done with this. The 84-year-old says, I want to keep doing this to my 90s. And I heard of a story from Dr. Cooperberg about a case of a guy who was well into his 90s, still on active surveillance, and around age 100, 101, got diagnosed with advanced prostate cancer. So I don't know, what's the lesson in any of that?
Yeah, I mean, unfortunately, we're all going to die of something eventually. I would say if you made it to 101 without any of the morbidity associated with treatment, and even if eventually, potentially died of prostate cancer, it depends. I mean, and I think the other thing I think we have to look at is not just death, but having prostate cancer when it's advanced can be tremendously painful, have a lot of morbidity. And so I would say in that 101, if the last 10 years of his life was extremely miserable, yes, you would have wanted to have diagnosed and treated that earlier to have a better last 10 years of the life. So yeah, there's no simple answer, but that's why I think at age 75, if you have no cancer seen on a multiparametric MRI, your PSA is low, you've been on active surveillance and just Gleason 6s, again, the likelihood is extremely low. Something bad will happen to you, but not zero. And if your option and you want to be tested, and if you have that reassurance that you're not going to be the exceptional patient that has advanced cancer, I would say that's your personal choice. You should have that option. I think the most important thing is for men to be informed, to realize the pluses and minuses of all the treatments and not treatments. And then once they're informed, make the decision how you want to handle your life.
I was stumped by this question. I have no idea what a stump tumor is. What is that?
Yeah, so it's something that we've studied probably more than anyone else. We've kind of wrote the largest articles on these tumors. So a stump is, so most prostate cancers, when you use the word prostate cancer, it's talking about tumors that arise from what we call the epithelium, the glands of the cancer, these little tubes in the prostate. And that's the one that's 99% of cancers in the prostate. But in the prostate, we also have stroma, which is the supporting structure. You can't just have glands, these tubules by themselves. They're held together with fibrous tissue, muscle, blood vessels, things that kind of keep the prostate together intact as a structure. And very rarely we can have tumors arising from this supporting stroma. And one of these is called stromal tumor of uncertain malignant potential, or abbreviated STUMP. Most stumps don't cause any trouble. They're extremely rare. But some stumps can become aggressive malignancies. And sometimes you can have a stump where there is a malignancy associated with the stump. So stumps diagnosed in younger men, I often recommend they get treated fairly aggressively, typically with radical prostatectomy. Stump in an older individual, I would check what the imaging looks like. If it looks like it's very localized and small, I often would recommend just follow-up.
Yep. Pretty soon, I'm hoping one of my colleagues will jump in here, but I can keep going. All right, here's something that comes up a lot. Can a biopsy cause permanent damage to the nerves that control erections? And can a biopsy spread prostate cancer?
Yeah, good questions. So let me ask answer the latter one first. I would say prostate cancer biopsies has not been shown to cause any spread of cancer, so that shouldn't be a concern for patients. I've seen rare, exceedingly rare cases where there is cancer tracking out of the prostate on a needle biopsy, but even in those patients, it doesn't mean necessarily that cancer is going to spread anywhere else, and that's exceedingly rare. So there's no good evidence that you have to be worried about the cancer spreading. In terms of the damages from multiple repeat needle biopsies, the biggest risk is infection. Even with antibiotics, there are some men who can become septic, and sometimes that sepsis infection, systemic infection, can be significant. You even need hospitalization, intravenous antibiotics, rarely even fatal. So that's probably the biggest risk, and why we try to decrease the number of biopsies that are being done. But also, every time you do a biopsy, it does cause some scarring, no question about it. With multiple biopsies, one of the risks is that it can entrap the nerves. It can cause a lot of scarring around the gland, such that eventually, let's say, if you have worse disease on a subsequent biopsy and you choose to have radical prostatectomy as your treatment, it can be hard to do a nerve-sparing radical prostatectomy in somebody who's been on active surveillance with a lot of biopsies because of all that scarring. So that's one potential complication. And there have been some studies suggesting with multiple biopsies, there may be some risk of decreased potency. So that can be a significant, or it can be a concern. So I think one of the important aspects of active surveillance that we're all trying to improve upon is to how to decrease the number of biopsies for men on active surveillance, space them out with a greater length between them, to minimize some of these morbidities. And for example, patients with very low risk versus low risk that we just talked about, that can be one criteria to say we can start spacing these out in these men with very indolent tumors. If we follow men on active surveillance for several years, the biopsies all showing favorable findings, that's reassuring for us that we can start spacing out these biopsies more. Older men, we can start spacing out these biopsies more. So there's a lot of, I think all urologists are trying to use criteria to decrease the number of biopsies that we are doing in men. Multiparametric MRI has been very helpful in that regard. It's been reassuring. It's not foolproof, but it is still reassuring. If we don't see a very aggressive lesion on multiparametric MRI, that allows us also to space out the biopsies as well more.
And what is the accuracy rate in grading, giving a Gleason score to a biopsy? You know, how often are they upgraded and downgraded? And what are I know you've looked at this yourself, but what is your success or failure rate?
Yeah, so my experience has been about 20% of biopsies that I look at that are diagnosed by outside pathologists. I will change the grade either up or down. I would say it's, it's 20% is, you could argue that's, less than a majority, but it's obviously a significant minority. And the major problem is for patients is you don't know the pathologist typically who's reading the biopsy. You might select a surgeon, you might, select a urologist, a radiotherapist, but typically you're not going to know your pathologist. And it doesn't always turn out that a good center necessarily means that you'll have an experienced pathologist in prostate cancer, for example, reading a biopsy. It just doesn't always work like that. So just because you choose a good academic institution, for example, that may have good clinicians, good overall reputation, the pathologist signing out your biopsy, may be good, may not be good. You just don't know. And that's the biggest problem. And so given how the grade of the prostate biopsy is so critical for treatment going forward, that's always been my recommendation to consider getting a second opinion, not only from me, but you can, consider getting it from other people as well. Just because, for whatever it is, the few $100s of the second opinion, to me, your life, and whether it's over treatment or under treatment going forward, it's worth that.
Let me be
Howard,
sure.
can I give you some relief? You had sought some relief, and you've done it.
I'll turn it over to you, but I want to have follow-up with Dr. Epstein about that 20%. So is it 20% are upgraded or downgraded? And is it this same 20% in your experience?
Yeah, so it's 20%. It can be altogether either upgraded or downgraded. Most of the time, it's plus or minus one grade group, like a 3+4 could be a 4+3. Occasionally, and again, it's just dramatic. I mean, you'll see something that's called, Gleason 6, and it's a Gleason 8, and you'll say, how could that happen? I mean, it just, and you look at the slide, you look at it twice, 3 times, and it's just that pathologist just doesn't know how to grade. Again, it's a minority of pathologists that are like that, but when you see those cases, I mean, that's a huge difference in terms of how that patient would be treated and what their prognosis would be. In terms of my accuracy of grading, very hard to tell because there's no gold standard in a sense. And so, I've never gone me against AI, for example, and even then I wouldn't necessarily trust AI because that's just other pathologists where you get the AI. So am I perfect? No, I'm sure I'm not. I try to be consistent within myself. I try to be, obviously follow the rules. And I think obviously we've done a lot of studies based on things that I've graded and they've correlated closely with prognosis. And that's basically the data we have.
Great. Mark, I'll turn it over to you.
Well, you don't have to turn it over to me, but I do have a question. But also, Dr. Epstein, on behalf of Active Surveillance Patients International, I chair the organization. And we really appreciate not only that you took the time, donated the time to do the video, but also donated your time today. And when I'm on these calls, I can't tell you how many times I hear, oh, get an opinion from Dr. Epstein. I think there must be 2 of you because I have no idea how you do all the things that you do. And I know how deeply as well that you support the process of active surveillance and the progress of active surveillance and saving men from overtreatment of prostate cancer has been great. And it's due in part to people like you. So there's a question here in the chat.
Yeah, so question is, I have a 4+3 on a biopsy, but a PIRADS 1. There's a disconnect there. And basically, as I said before, the disconnect is multiparametric MRI has been a quantum leap forward for imaging for prostate cancer, but it's not perfect. And sometimes they'll, on both sides, you might have a PIRADS 4 or 5, and it may not be a significant cancer, or maybe even no cancer. There's been false positives. And then sometimes there are these, what we call false negatives on the flip side, where you have an aggressive cancer, but the imaging looks favorable, like the case you just described. In that scenario, you basically just have to go with the pathology. The pathology is the ultimate.
Yeah, Howard,
as long as it's accurate. I mean, now in a case like that, maybe the patient would want a second opinion just to make sure, given that disconnect, that it's truly a 4+3 and it wasn't a misread. But I wouldn't be surprised with a 4+3 and a PIRADS 1. Again, that can happen.
Yeah, Mark, are you okay, or can I go?
I'm okay. I don't know how I'm coming across now. Now, Dr. Epstein, it is 1:30, and you had agreed to end at 1:30. Should we continue, or what's your preference, Dr. Epstein? I want you to drive this because you've been very generous with donation of your time. So we can end right now.
We can
or
do like another 15 minutes if you want, or that'll be fine.
That'd be good. I can dive in with another question, Mark.
Go ahead.
Mark and Dr. Epstein both are alluding to technology changes, AI for one, but there's another technology that's on the horizon, I think, for some of us. And I'd like to get your perspective, and that's PSMA PET scanning. And we're starting to hear about patients with Gleason 6 who may have some questions on the edges there, and they end up getting this technology. We got a note here from Richard from Ohio, who said, in lieu of having a second biopsy, I had a PSMA PET scan. Now he's a 3+4. And he said that the test provided the information I was most interested in obtaining in terms of the evidence of metastases. So, what role do you see? What is PSMA PET scan? And, what role do you think it's going to play, and how is that going to affect biopsies?
Yeah, so just like prostate makes PSA, prostate-specific antigen, prostate cells also make another substance called prostate-specific membrane antigen, or for short, PSMA. And basically, there is an imaging where you can basically light up. The imaging will show it as like a red positive color wherever you have this PSMA. Now, your normal prostate will have some PSMA because there's PSMA in the prostate. So where PSMA PET scan has been used the most is to look for disease outside the prostate where you should not have any PSMA. But the test can be difficult. It can be kind of low-level, non-specific staining. I would say in general, for the men with low-risk prostate cancer who are, thinking of active surveillance, for the most part, PSMA PET scan doesn't have a major role because the likelihood of them having disease outside the prostate is exceedingly low unless their PSA is very high. So that would be the only situation if somebody's on active surveillance with a high PSA. Again, there's a disconnect there. Yes, maybe PSMA PET scan, might be useful to look if there's spread of cancer outside. But to looking in the prostate, at this point, it's not something that's being currently used widely to determine who needs biopsies or who needs repeat biopsies, et cetera.
Yeah, Mark, you want to?
Well, how long after a biopsy is your tissue viable for a second opinion?
Yeah, so the good thing is, I could look at a prostate biopsy done in the 1930s, done at Johns Hopkins, and still look at it and make a diagnosis on it and still even do special stains on it. Maybe molecular wouldn't be that good after that many years, but that would be the only thing. So the tissue lasts for, decades and decades for somebody to send out for a second opinion. So there's never a concern on that respect.
Okay.
There's a question from a fellow Chicagoan here who is talking about the interval between biopsies. Now, when I started 13 years ago, I was having a biopsy every year. I think they were at the University of Chicago, they were following a protocol from Johns Hopkins. Eventually, after 5 or 6 years, doctor says, well, we know your prostate pretty good. I'm going to put you on a vacation. So I didn't have any more biopsies for about 3 years. Switched doctors to another institution. He did a baseline. Now I've gone 6 or 7 years without a biopsy, and I'm just followed with a PSA, actually a specific kind of PSA, a phi test, which I think is also used at Hopkins. But what about these intervals? I mean, yes. Dr. Klotz in Canada goes 3 to 5 years. I've been out 6 or 7 years, and I'm followed, just with a little bit of blood. Is that good or?
Yeah, so I would say it's riskier. So even though everybody on active surveillance, including those at Hopkins, are followed with, every 6 months PSAs, every year PSAs, whatever, different intervals PSAs, with the rare exception of somebody who's PSA who really just jumps up dramatically, otherwise there's just fluctuation in PSA, and it doesn't end up being helpful to predict in everybody's studies, not just Hopkins studies, but everybody's studies, that what's happening with the PSA ends up not being that helpful to predict who's going to have worse cancer down the road. And so we do the test partly because it's cheap, doesn't cause a lot of trouble for the patient. But if you say, how reassuring is it in terms of if I were a patient just being followed by PSA, I would say not reassuring at all. With the exception of as long as it doesn't jump up super high. But, you could still have bad disease and your PSA doesn't change that much, potentially. So ultimately, it's still the biopsy. To me, I've just seen, again, you have to decide globally, society versus you as an individual. I've seen so many cases, and you can call it anecdotal, where 3 years go by, 4 years go by, no biopsies, and you went from, nothing, low-grade cancer to horrible cancer. 3 or 4 years is not an insignificant amount of time. 5, 6, obviously longer. If I were on active surveillance, I would probably space it out at most 3 years, 4 years, probably 3. I would feel comfortable with. Beyond 3, as a person, just personally, I would not feel comfortable. But again, that's based on my experience, and my experience has been seeing these horrible cancers that have developed, 3 years later for sometimes. Now, obviously, the older you are, that equation changes, and probably, yes, I would start spreading it out more or dropping them altogether, as I've talked about earlier. But in somebody who's younger, before 75, I would feel uncomfortable, myself waiting 4 or 5 years in between biopsies, because again, PSA to me is just not that helpful.
And Mark?
There's a question here. I don't know, Dr. Epstein, whether this is fair to you, but we'll ask it anyway. Does anyone have thoughts on using testosterone replacement therapy if on active surveillance?
Yeah, good question. So there's the company's policy, and then there's kind of medical policy. So the company's policy would basically say, don't do it. But a lot of that is medical legal. They don't want to get into trouble. Typically, patients who are on, so the whole story with hormone therapy replacement and prostate cancer is, obviously we used anti-androgen therapy to treat advanced prostate cancers. But patients who have low testosterone, who are basically taking testosterone therapy just to get the testosterone levels in the normal range, not high range, obviously, we just want to bring their testosterone normal range. There's very little data, hardly any good data, to say that that fuels the fire for prostate cancer and makes the prostate cancer worse. So, I think the data is such that obviously you have to talk with your clinician in terms of their comfort zone. But in general, there's not a lot of data to say you're harmed by taking hormone therapy replacement, getting your testosterone in the normal range if you've been on surveillance for prostate cancer.
Thank you.
Okay.
Howard, I'm inclined to, do you have other questions? I'm inclined to let Dr. Epstein get back to his Saturday.
Well, here, I have a few other questions here.
Go ahead.
I have a feeling we could go on for the next 3 hours.
Okay, well, we can go to 1:45 or so. I'm good with that. Yeah.
Okay. Gary asks, he mentions Decipher test, but let's say any genomic test be run after each biopsy, and how valuable are these genomic tests? For example, in Europe, they don't pay any attention to them at all.
Yeah, so as I mentioned in the video, the few studies that have looked specifically at active surveillance patients with these genetic molecular tests have not found them to be useful to predict who's going to have worse disease on follow-up. All the studies that have shown those molecular tests to be useful are studies looking at biopsies in men who then have radical prostatectomies and kind of working backwards. That's a different ballgame. You want to look at it specifically on the group of patients you're planning on using it on, active surveillance patients. And the biggest problem is with active surveillance is missing the worst cancer. And so if you don't sample that worst cancer, the molecular test is being done on cancer that's not the worst cancer and may not be representative. So I'm not a big fan on it. If on the other hand, if somebody wants to get it done, they're expensive. You can get it done. It's what I would say is I wouldn't put all my decision making on that molecular test. Use it as just one piece of information, and where it might be the only thing I would say, it might be reassuring. Most of the time, these tests are going to come back as low risk for most men, and in that scenario, it just might be psychologically beneficial for the patient. But if it were myself on active surveillance, I wouldn't be ordering these tests.
I think this was alluded to in the video, but you can have a second opinion, you can have a third opinion. I mean, should people be shopping for an opinion until they get one that they like? I mean, what's the best strategy for that?
Sure. Yeah. In general, in pathology, I wouldn't recommend that. I think, you have to decide who you trust. And, in general, go with that. Now, one thing I would say, and this has happened a couple of times, for example, I've gotten cases from some other institutions. I disagreed with their report, and the patient called me up and said, report X from very good institutions called it this, you called it differently, what's going on? And, I won't have a knee-jerk reaction saying I'm right, they're wrong. What I'll say is, let me look into it. And a couple of times I've looked into it, and it turns out I wasn't sent the right slides. They didn't send me all the slides. And when I got all the slides, my diagnosis changed. And so what I would say is choose somebody who you want for a second opinion. And if there's a real big difference, it's reasonable to reach out to whoever you chose for a second opinion to just say, can you explain where that second opinion came about? Could you look at the slide again? I'm always willing to look at the slide again. It's make sure I didn't make a mistake, or again, look into other reasons why there could have been a disconnect. So I think that's important. Again, choose the person you trust, but also feel comfortable to question the person you trust if there is a real difference.
You bring up another question, which is, do you run into this where, let's say, the urologist picks certain slides to be viewed, and is that disadvantageous for the patient? Should you be getting the whole group of slides?
Yeah, I would say 95% of the time, if they only select certain slides, it's let's say the slides with the cancer, for it to be reviewed, it's going to be what you need. Very uncommonly, there may be something on the slides that were not sent that could be significant. So probably, it doesn't cost more to have the whole case sent. So if I were a patient, I would probably say just send the whole case, make sure they send the whole case. There's just no downside to it.
Okay, now I think maybe we can close with one other question. I keep getting a note that we should put Ricardo on, and I have no idea what Ricardo's question is, but Joe, if you could open it up to Ricardo.
Go ahead, Ricardo.
Yeah, hi. I'm 85 and have been treated at Hopkins by Ballantyne Carter and now Christian Pavlovich. And my PSA, it fluctuates. Now, it went up to, let's see, about 12 back in November. And that's the highest it has ever been since, last 20 years being treated at Hopkins. And so 6 months after the 12, it came down to 7, 2 months ago. And then I had another one done a month after that, and it went up to 7.6. So my question is, what's a high PSA? Does it depend on the patient? How does this work? I don't know. I don't have a feel for what a high PSA means.
Right. Yeah, so a high PSA somewhat depends on patient age. So for example, a PSA of 5 or 6 in somebody who's in their 40s or even young 50s is high. A PSA of slightly over 4 or 5 in somebody who's 80 is not high, just because there's growth of normal prostate overage. So that's one thing that gets factored into, is it a high PSA? The other thing that gets factored into, is it a high PSA, is, and this is controversial, but I think there is still data that has merit, how the PSA changed over time. So if your PSA is consistently going up 2, 4, 6, 8, that is a worrisome finding versus if it's staying the same over time. Anything over 10 typically is considered a high PSA. Most of that is time due to cancer, not always, but most of the time, unless your prostate is huge. If you have a 100-gram prostate and a PSA of 10, that's a normal PSA for that size of the prostate. Some things can cause PSA to bump up quite dramatically, like an infection. Prostatitis can cause PSA to bump up to 10. So sometimes if you have a rapid increase in PSA, some clinicians will treat you with antibiotics for a few weeks. And if that PSA drops down quite dramatically back to what it was before it bumped up, the assumption is it was prostatitis, not cancer. I find sometimes clinicians and patients are confused about, if your PSA goes from 7 to 7.6 to back to 7 to 7.5, that's just bouncing around PSA. That means nothing. That's just noise. The PSA can bounce around up to even 10 to 15%, just normally depending on the lab. If you go to different labs, it's when it really jumps up dramatically that you have to worry. If your PSA, and I don't know what your baseline PSA, but if your baseline PSA was in the 7s, went up to 12, and then back down to 7, basically, I wouldn't be as concerned about that 12. If it stayed at 12 and the next one was 12 or 13, 14, that's more concerning.
just to complete
Ricardo, I
that.
think we're gonna have to move on.
My PSA, according to Carter, was huge. It was over 100. So, I mean, the size of the gland was
Right, so
huge.
that's
So
reassuring. Yep.
yeah. Okay, thanks.
Thanks, Ricardo. I have to sneak in one last question because it comes from the country of Panama. And he's asking a follow-up of me, which I think can be answered by you, Dr. Epstein. He is asking what the PHI test is. And I'm wondering if PHI is used for active surveillance at Johns Hopkins.
Yeah, so there's several different variations of PSA testing, HK2, the PHI test, PSA density, several others as well. We've shown them to be statistically helpful with active surveillance. But again, for the individual patient, we're not using them routinely to make decisions. We still clinically relying on PSA density as the main PSA parameter that we use for clinical decisions. Now that again may change over time. And again, we published papers showing PHI and HK2 are helpful in active surveillance, but how much they add relative to PSA density and multiparametric MRI, biopsy grade, this point, it's unclear if they add that much to be used routinely. But what you do find in urology is a lot of individuality. And so a lot of clinicians who have some of them have a favorite test they like to use and they may use it, others may not. So there's not necessarily gold standards or uniformity across the country in terms of which test people are using for active surveillance.
So Mark, what do you say? We call it and give Dr. Epstein a break?
We should. He's been more than generous with his time, and it's good to know, Dr. Epstein, that you're on our team. Part of what ASPI is about is to reduce patient anxiety, and your manner does that, and your knowledge does that. So thank you so much for today.
I appreciate very much the opportunity to speaking to you and hopefully helping some of the patients out there.
I think so. And just a reminder to everybody that in a few days, this video will be available, and the Active Surveillance 101 video will be posted as well. So, Mark, what do you say?
Thank you. Thank you all who have attended too, and I hope you find this useful. I look forward to seeing you at on our next webinar, which will probably be on imaging. So thank you all for attending.
Thank you so much. Have a good rest of the weekend, everyone.
Yeah, you too.
Thanks, everybody.
Yep. Bye-bye.
Take care.